I'm Gail Hadley. I'm the Technical Director of the Vascular Ultrasound Core Lab at Mass General Hospital. This presentation will discuss the details on how to conduct a renal artery duplex scan. The incidence of renal artery stenosis is reported to occur in approximately 5% of those patients with hypertension. However, over the last number of years, there has been an increased number of reports that have identified those patients that have high risk factors for increased incidence of renal artery stenosis. Olin and others were the first to identify the association of other atherosclerotic disease with renal artery stenoses. So if a patient would have carotid artery disease, iliac artery disease, they have an increased risk, 10 to 40%, of having a renal artery stenosis. Peripheral arterial disease, so basically your atherosclerotic patient. Of those patients with renal vascular hypertension, 75% of those will be atherosclerotic in nature. The prevalence of disease is along the ostium or proximal portion of the renal artery. Now, there's a remaining 25% of patients who will have fibromuscular dysplasia, known as FMD. The difference between it's a different plaque, or it's a different process. It's really not plaque than atherosclerosis. It's usually not as easily identified. However, the location of the vessel makes you suspicious because it occurs in the mid to distal renal artery, while atherosclerosis occurs more often in the ostium and the proximal renal artery. So it occurs more often than previously described. Early detection is essential to avoid loss of renal function, and the proximal renal artery and origin of the vessels are actually the easiest to identify using ultrasound. Now, in order to conduct a visceral vessel scan and be able to identify accurately the renal arteries, you need to have a thorough working knowledge of the visceral vessel anatomy. So if we look here at the anatomical drawing, we see the abdominal aorta, we see the celiac axis, then the next vessel or branch off the aorta is the SMA, the superior mesenteric artery, traveling inferiorly. And then just below the SMA, the right and left renal arteries arise slightly anterior and then coursing laterally to the kidneys. So you can see that although there are numerous vessels in the abdomen, that it's just a very narrow field of which we need to work to be able to identify the right and left renal arteries. It's important to note that the right renal artery is generally longer than the left renal artery. You can see that here in this diagram. When we look at the image, by placing the transducer subxiphoid in a transverse view, it's best to use the SMA as your landmark. Usually you can see the bright echoes surrounding the SMA, and then just immediately inferior to the SMA, you will see the left renal vein crossing anteriorly over the aorta. We see the aorta. Now you don't see the renal arteries, but they are located slightly posterior to the renal veins. But now you've narrowed down your field of view in which you need to be able to locate and search for the renal arteries. Now, renal artery anomalies. In order to search for the renal arteries, you do need to be aware of any anomalies that you might encounter. The most common is multiple renal arteries. A lower pole is generally the one seen most often. However, you can have an early bifurcation, as we see in this diagram here. There's very, very small trunk of the main renal artery, then we have this early bifurcation. At other multiple renal arteries, you can see that we actually have independent origins off of the aorta. These can sometimes be very small and difficult to identify. Here we have an image of the aorta, and we see renal artery number 1 and right renal artery number 2. if the renal artery, the accessory renal artery, is identified, it is important to thoroughly evaluate that renal artery for stenosis. Another anomaly could be a retroaortic left renal vein. As we noted in the image, we have the left renal vein crossing anteriorly over the aorta as one of our landmarks. If the left renal vein is retroaortic, it would cross the aorta beneath the aorta on the image, and if you were to try and find the renal arteries down here, you would never find them because they're actually up here. But this actually is one of the less common anomalies that occur in the renal arteries. Now, if you see kidney anomalies, horseshoe kidneys, pelvic kidneys, these are often associated with variances in the anatomy of the renal arteries. So one should be suspect if they see an anomaly of the kidney to suspect that the renal artery might not be in its normal location. Equipment. It is very, very critical to have state-of-the-art equipment. You cannot do this with smaller units. You need to have a lot of power. You're going to look at small vessels at very deep depths, so you need low-frequency transducers, warm acoustic gel. Additional tools, use everything that you have. It includes color Doppler, color power angio, harmonic imaging. You will need to optimize the image in order to be able to identify these small renal arteries. Recording device, and it's always critical to optimize your image so that you maintain frame rates. Patient prep. In order to successfully scan the patient's renal arteries, they need to have an aggressive prep. They should remain NPO 8 to 12 hours prior to the exam. They should be asked to have a low-fiber meal the evening before, have no cigarettes, and no chewing gum. They should have the scan done early in the morning. That way the patient isn't up most of the day taking in a lot of air and creating gas even though they've been NPO. When the patient arrives, you should explain the breath holding techniques, because it's critical that when you need the patient to hold their breath, when you found a stenosis, that they don't take too big of a breath and completely move the vessel out of your field of view. Simethicone, it does not get rid of large amounts of gas, but simethicone might be able to help with small pockets of gas that come in once you've started the exam. There's no contraindication to simethicone, so it is safe. You should always do a bilateral exam, renal arteries and kidney. So a complete evaluation of the renal arteries is all the way from the ostium off of the aorta to the renal hilum. And if you find any abnormality of the renal artery, it should be confirmed from 2 views. So when we look at the images here, the 2 views that are used most commonly to identify the renal arteries would be the anterior approach. However, the problem with the anterior approach, as you can see, the renal arteries will frequently show up at 90 degrees off of the aorta in your image, and that does not leave for good Doppler angles. So in order to assess the patient with the best Doppler angles, the lateral decubitus position is the better position. It's also helpful to place a pillow under the patient's side that they're lying on, because with the pillow, you can now put the arm above the head and open up and try and move the rib cage away from the kidney. Here's some examples. Here's the anterior approach with the patient resting comfortably. Here's the lateral decube position. You can notice that the arm is extended up over the head to open up the space between the hip and the rib cage. It's also important to notice the technologist position. This is a demanding exam, and the technologist should remain comfortable. Protocol. You need to obtain a longitudinal image of the aorta, obtain spectral Doppler from the level of the SMA. You need to do direct evaluation of both renal arteries, then conduct spectral Doppler of the entire renal artery. Indirect evaluation includes hilar analysis, renal parenchymal waveform evaluation, and kidney length measurements. Exam components include the B-mode image, which provides the anatomical information, the pulse Doppler, which provides the hemodynamic information. The pulse Doppler is where we get our diagnostic information from, and additional tools such as color power, harmonic imaging. Here we can see a complete exam. We have the aorta. Here's the right renal artery extending out to the hilum, into the kidney, and then we have the kidney. We've turned on color, and you can actually again see aorta and the renal artery coursing towards the kidney. If you do not get a complete exam, this must be noted in your report. So, starting at the subxiphoid approach, we have the sagittal view of the abdominal aorta at the level of the SMA. Using a 60-degree Doppler angle with the cursor placed center stream, we obtain the aortic peak systolic velocity. This is what will be used for the renal aortic ratio. Evaluating the renal arteries from two views, we will have multiple Doppler angles. However, if the Doppler angles are less than 60 degrees and the exam is consistent with stenoses from both views, the accuracy goes up. If you have a normal velocity from one view, and in this case we can see from the lateral decube approach, the right renal artery has a velocity of 131. If we come from the anterior approach, you can see the 90-degree course of the vessel from the aorta. Attempting to insunate that portion of the vessel does not give us very good Doppler angles, and in trying to measure this at 70 degrees, we end up with a peak systolic velocity of 277. So in this case, the two views do not confirm stenosis, and since you cannot really make a stenosis normal, we're talking about hemodynamically significant stenoses of over 60%. This patient is normal, and this is an error based on Doppler technique. The image from multiple views is also very helpful in identifying where you want to place your sample volume. Here's sort of a coronal view of the aorta. We call this the banana peel approach. We have the origin of the right renal artery. As you can see, that provides excellent Doppler angles. Here is the left renal artery. And again, so both renal arteries, the proximal segments, provide good Doppler angles to evaluate the arteries. Here's the anterior approach from the same patient. Again, the right renal artery, 90-degree Doppler angles, but the left renal artery actually, due to its course, provides rather nice Doppler angles. So this needs to be assessed individually from each patient. A complete exam, here's the peak systolic velocity or spectral Doppler from the abdominal aorta. Then we move into the proximal renal artery. Then we move into the mid-renal artery and into the distal renal artery. It's important to note that the signals throughout the renal artery are essentially the same. And what's critical about that is if you see a change in these waveforms, it might actually indicate that you've missed something, and then you would need to go back and identify why there was a change in the shape of the waveform. They should remain uniform and consistent throughout. So, exam components, walking the sample volume through the entire course of the vessel. This is to identify the maximum peak systolic velocity. Doppler interrogation is performed in the sagittal view only. You're using a small sample volume, place center stream or center to flow jet. In the renals, this can be difficult. Doppler angles of less than 60 degrees. Use angle correction with the cursor aligned parallel to the vessel wall, and calculate the maximum PSV from designated locations and any areas of abnormalities. And since we're looking for hemodynamically significant lesions here, often with the belly you will get some bruits, color bruits from the soft tissue. Whenever you see a color bruit, it should be evaluated with your Doppler. The diagnostic criteria is based upon the calculation of the renal aortic ratio. That's taking the maximum peak systolic velocity from the renal artery and dividing it by the maximum PSV in the aorta at the level of the SMA. Now, the limitations to this technique, abdominal aortic aneurysms will give you an erroneous spectral Doppler velocity, or if the aortic PSV is less than 40, this will give you a falsely elevated renal aortic ratio. So it is important to note that when the abdominal aorta is not normal or has low velocities or extended high velocities greater than 125, the renal aortic ratio is not calculated. Now here's a normal renal artery looking at the waveform pattern. We can see that we have continuous forward flow throughout diastole. This is considered with decreased pulsatility that's observed throughout the renal artery, always providing flow going towards the kidney. Now the diagnostic criteria, renal aortic ratio of less than 3.5 is considered normal. Now the associated absolute peak systolic velocity is a PSV of less than 180 is considered normal. A diameter reduction of less than 60% is consistent with an RAR of less than 3.5. However, the absolute PSV is 180 to 200. The key thing is to note that you will find no poststenotic turbulence in patients that have a less than 60% stenosis. 60 to 99% diameter reduction is consistent with an RAR of greater than 3.5, a PSV of greater than 180, and the presence of poststenotic turbulence. Now, there's additional criteria that was done at Bowman Gray, and this is actually one of the larger series, and they identified that a peak systolic velocity of greater than 200 centimeters a second with PST is consistent with a 60 to 99% stenosis. So there continues to evolve new criteria for the diagnosis of renal artery stenosis. Occluded, no detectable flow, and most often you will see either no flow or a monophasic low velocity signal out at the hilum or within the parenchyma of the kidney. Now, talking about poststenotic turbulence, it's important to identify this transition through a stenosis. So this is going to represent what we see proximal to the lesion. This is the maximum peak systolic velocity from within the lesion. And here you can see as blood flow is trying to restore itself back to laminar, we have random and chaotic flow, which can be seen here in this waveform, and that's known as post-stenotic turbulence. Here's a very real patient that has a renal artery stenosis. You can see the elevated peak systolic velocity, diffuse spectral broadening. Here's the post-stenotic turbulence, and then beyond the turbulence, once you move out from the stenosis, you will see the delayed systolic upstroke and monophasic waveform known as your tardus parvus waveform. Here's a normal patient. The PSV is less than 200 centimeters a second. The waveform shows decreased pulsatility throughout. And this is right at the origin of the renal artery. As we move to the mid-renal artery, we see a PSV of 154. Again, the waveforms are a match, so we know that this is an essentially normal renal artery up through the mid portion. Here we have a left renal artery. The stenosis, the little bit of color aliasing that's occurring, is actually being covered by the sample volume. This is a very, very tight lesion. Here's the aorta. You can see we're aliasing in systole. This exceeds 500 centimeters a second. And even in the presence of aliasing, you can't calculate the RAR, but even if you used 500, this patient's RAR would exceed the 3.5 scale. Here we have a 60 to 99% stenosis. This patient has a peak systolic velocity of greater than 600, and again with post-stenotic turbulence. You can actually see the bruit down here on the spectral tracing. Here's the sample volume. So again, this is at the proximal portion of the renal artery. Here you can also see the post-stenotic turbulence and color bruit. Now, occluded renal arteries. The renal arteries are not often seen when they're occluded. Occasionally you might be able to see a little stump off the aorta. This is the right renal artery, and there's no Doppler signal. But in the presence of being able to identify an occluded renal artery, it's important to go out to the kidney and the hilum to see if this kidney is actually viable via collaterals. And here in this case, we will look at the kidney length, which was 9 centimeters, small, but still viable. It had peak systolic velocities that ranged from 25 to 30 centimeters a second out at the hilum, and this was very, very reproducible. Here we can see the various waveforms from throughout the kidney. All of this speckling is due to the increased power level used trying to detect these low flow arterial signals from the kidney. Here's our 9 centimeter kidney, and you can see actually by looking at the echogenicity of the kidney that it actually looks like a relatively healthy kidney. Here's the angiogram with the collateral vessels as detected by the ultrasound, and by insunating these vessels, this gave the surgeon an opportunity to do an aortic to renal bypass and actually save this patient's kidney. Now, fibromuscular dysplasia occurs in the mid to distal renal artery. It gives you this sort of strand or beaded appearance of pearls. Now, this generally does not cause as high of an increase as atherosclerotic disease, so you do need to be aware of that if you see this presentation or you see the high velocity waveform from a young female in the mid to distal renal artery, to suspect FMD. Now, the one thing that's interesting, because this is different than the pathology of atherosclerosis, that the hilar and parenchymal signals are not affected, meaning that you won't see a delay in the systolic upstroke. Indirect findings are those that are caused by the secondary changes from the hemodynamically significant stenosis. As you get the energy and pressure loss across the lesion, this will change the waveform shape and the velocities. This is important to recognize because it helps the physician identify and maybe predict a response to treatment. Patients have been treated for renovascular hypertension, and although they've improved the vessel wall and removed the lesion, the patient remains hypertensive. So essentially, they have surgical success but a clinical failure. So the newer studies are trying to identify those patients that are amenable to revascularization and have better outcomes. This includes doing hilar waveform pattern analysis, renal parenchyma, resistive index, diastolic systolic ratios, and looking at kidney size. Renal hilar analysis, the tardus parvus waveform. The acceleration time of less than 100 milliseconds is normal. Anything greater than that is consistent with occlusion or stenosis. Renal parenchymal flow, assess both upper and lower poles, identify the peak systolic velocities, identify the absence or presence of flow. Kidney length. Any kidney less than 9 centimeters a second is considered abnormal. However, if there's an asymmetry between the right and left kidney, that is considered abnormal. So a patient could have a normal sized kidney of 10 centimeters, but if the contralateral kidney is 12.5, the smaller kidney is actually considered abnormal. Now, kidney length is important because it's found that those patients that have kidneys that are less than 7 centimeters actually do not respond well to surgical intervention or any other reconstruction. Between 8 and 9 is variable depending upon the amount of medical disease present. Now, the identification of medical renal disease is identified by either doing the diastolic systolic ratio or measuring the resistive index. A DSR of greater than 0.3 is considered normal. An RI of less than 0.7 is within normal limits, and greater than 0.8 is consistent with renal disease. Markedly abnormal diastolic systolic ratio and or a markedly abnormal resistive index are suggestive that the patient would not fare well with intervention. Kidney length measurements, and it's important to note that when measuring the kidneys, due to the awkward plane that they lie in, it is best to take 3 independent pole-to-pole measurements, average those to determine that patient's kidney length measurements. Unilateral small kidney is associated with renal artery stenosis. To measure the Hyler waveform, you want to change the sweep speed so that you can identify where the actual peak occurs. Here's the first onset of systole, and here's the first peak. The second arrow points to the maximum peak. If you were to measure the maximum peak, this patient's acceleration time would be abnormal, while the acceleration time is actually normal. Another component to look at is the early systolic peak. This is very suggestive of a normal compliant vessel. Here's just a diagram showing you what you're measuring. Here's your time frame down here on your scale, and you're measuring the onset of systole to the first peak. Parenchymal waveforms. These are helpful in measuring the resistive index and identifying the absence or presence of medical renal disease. So you want to assess both the upper and lower poles. By using color Doppler here, you can see that you have nice filling throughout the kidney. The clinical utility, it helps identify those patients who might fare better with revascularization. If you have a DSR of less than 0.8, these patients do not fare well with intervention and generally are considered clinical failures. This also is apparent in those patients that have an end diastolic velocity of less than 5 centimeters a second or a resistive index of 0.7. Interrenal waveforms can be affected by the degree of stenosis, the etiology of the lesion. As noted earlier, fibromuscular dysplasia generally does not affect the waveforms out in the parenchyma and appear to be essentially normal. The resistance and compliance, the age of the patient, arterial pressure. However, they are most predictive when markedly abnormal. If you find an abnormal waveform out at the hilum and a delayed acceleration time, this is highly predictive of proximal renal artery stenosis. However, if the waveform is normal, it really does not imply whether the vessel is patent or stenosed. The limitations of renal artery duplex include duplicate renal arteries. 14 to 25% of patients are reported to have multiple renal arteries, and this is generally the primary source of a false negative exam. Renal artery duplex is not helpful to identify branch vessel disease. In the presence of a large abdominal aortic aneurysm, the renal arteries are generally splayed out around the renal artery, the aneurysm, and it makes it difficult to see the origins and proximal segments of the renal arteries. Post-op abdominal surgery, generally the patient has too much air post-op, and it can take up to 3 to 6 months before you could get optimum images of the renal artery. Renal duplex does not identify lesions of less than 60%. In those patients with small kidneys that have been atrophic for a long time, they may have an associated small renal artery, and it's not occluded and it's not from renal disease. This can make the differential difficult. Bowel gas is the nemesis of renal artery duplex. That's why it's important to employ an aggressive prep the evening before, and the limitations of using multiple Doppler angles, particularly those over 60 degrees. Just showing you some of the limitations. Here's the duplicate renal artery. Here's a patient that's gassed out. If you can't see the aorta, like in this particular image, simethicone will not help you with this patient. Interpretation considerations: exam quality and completeness, the Doppler angles used, if the patient's abnormal, were the findings confirmed from 2 views, did the patient have the presence of medical renal disease, do the direct and indirect findings correlate, and is your focal increase in velocity focal, or is it extended throughout the entire renal artery? Corresponding findings: the waveforms should be symmetrical from both renal arteries and the renal parenchyma. The Hyler analysis, both the acceleration time and early systolic peak, are they present? The kidney size, are they normal and symmetrical? Is there no focal increase in velocity? The waveforms remain uniform and consistent throughout their course, and there's no turbulence. Thank you very much.